Okay, so far we've just been talking about these waves outside of the body, and I've been giving some examples, but let's look at what these waves and these circuits end up looking like within the body. So taking those kind of crude diagram that I showed you before, the electrical circuit that the body would be part of. So when we attach the electrodes for eStim, so we'd have at least two electrodes always have to be in contact because we have to include the body in part of the circuit. So the electrons are going to flow from the machine into one electrode, travel through the body, out the other electrode, and back to the machine, back to the pole. So when we talk about the body, we actually have a combination circuit where we have a series as well as parallel circuits involved. And so when the electrons leave the machine and go through the electrode, it goes through the skin, which is actually the biggest place of resistance in the body, is the skin. Very little contact or water content in that outside layer of the skin. Then it goes through the fat, and then it reaches all of these things that are kind of all different resistors with different resistances. So again, blood, muscle, bone, nerve, ligament, tendon, fascia, all that would be considered in here. And the current gets a choice of kind of how it moves through that. And so again, it's going to be more likely to take the path of least resistance, but some of the current will always flow through all of these. And then it's going to leave that and come back up towards the surface of the body. So go through the subcutaneous fat again to the skin, and then back out the electrode back to the power source. And so you can kind of see that in this diagram from your book. So where the electrode, we want to create a medium that allows the electrons to flow. So usually this is a gel, or if we're using self-adhesive electrodes, the gel's already in place that allows those electrons to flow. Then it reaches the skin, which is a big insulator. Same with the adipose tissue. So those are things that don't want to let a lot of current flow. And then we get down to the excitable tissues, so cell membranes, nerves, muscle tissue, and those become conductors because they will adjust to the flow. So each tissue is going to have a different ability for us to conduct. So you can see here that this kind of mimics this diagram where we go through the skin and the adipose, but once we get through there, then we have this parallel circuit, right, where the electrons get to choose kind of which tissue it wants to go through. And what happens is when we get into the body, again, we have electrons that are flowing through the material, through the conductor here, and gets to the electrode. But then once we get into the body, then it's about the shift in ions. And so because this is the negative side, right, negative ions are going to want to leave over here and transmit over this side, and positive ions are going to shift this way. And it's those ion shifts that give us the results, the physiological results that we have. Now, when we think about, again, if something is a good insulator or a good conductor, you really want to think about water content when you're talking about within the body. And so skin is a big insulator. It doesn't have a lot of water content, especially the outer layer of the skin. Muscle is a really good conductor. Blood is a really great conductor, one of the best conductors. Tendon, fat, and bone are really poor conductors, okay, because they don't have a lot of water content. Nerve is a great conductor, but nerve is surrounded by fat cells, right, and what we call Schwann cells. And so we have to get through that fat in order to target the nerves. So again, we have to have potentially high intensities or high durations in order to target some of those. When we talk about excitable and non-excitable tissues, excitable tissues are things that are directly affected by the electron flow. So nerves, muscle fibers, and cell membranes, okay? Non-excitable tissues are the bone, the cartilage, the tendon, adipose tissue, ligaments. They're indirectly influenced. So when these ions shift from the excitable ones, we have perceived things that happen in the non-excitable, but they're secondary. They're because of the results of targeting the excitable tissue. So one thing to kind of note, like I said, excitable tissue, cell membrane is an excitable tissue. However, because of its structure, it's actually one of our greatest resistances because of that lipid layer, right? So if you think back to your anatomy, you had the bilipid, right? So that lipid layer, and then you had the hydrophilic layer in the middle, and you have to have channels open up to that. And so the cell membrane is really wants to be excited, but because of that lipid layer, it's actually an area of great resistance. So we have to overcome that resistance of the cell membrane, which is the action potential that we talk about. Internal organs actually have a decreased resistance. So the heart itself. So when we'll talk about not wanting to put the electrodes kind of directly to the heart or directed to the heart. It doesn't have as much to do with the heart muscle fibers itself. It has more to do with the electrical stimulation points, so like the carotid sinus and those electrical points, than it does with the heart muscle itself. So if we said that skin is a really kind of poor insulate or a poor conductor, it's more of an insulator, there are certain areas of the skin surface that are more prone to allow electrical activity to enter. And those are what we call stimulation points. And there's three major types of stimulation points. So these areas of the skin that have decreased electrical resistance. There's trigger points, which are kind of these high areas of activity for usually tension. You have motor points. Okay, motor points are certain areas of skin above the muscle bellies that are more excitable. And so that's going to be really important when we start talking about our muscle re-education and being able to target those. And then there's acupuncture points, which again are the kind of these structural areas that have this decreased resistance. And so various charts can give you those. So I've posted a couple of those charts up on Moodle so you can see kind of some of these motor points and acupuncture points. Another thing that increases the likelihood of the electrons wanting to flow in that area, so decreasing the resistance, is again any area with a high fluid content. And so inflammatory tissues have a higher fluid content because of the edema and because of the increased blood flow. So the vasodilation and the shift in the fluid dynamics, the hemodynamics of the bloodstream. And so usually E-stim will target more easily those areas of inflammation than they would typical healthy tissue. So another thing to kind of pause on this picture is to talk about kind of the machine itself. And so when we're trying to produce this electrical energy to enter the body, you need to have what we call a generator. So for most of our modalities, that's going to be a standard 120 volt alternating current generator. So it takes the electricity coming in from the walls and creates 120 volt alternating current. Some of our modalities will also be battery operated. So those are going to be DC currents. So some of those have to actually also have what we call a transformer, which would take the DC current and turn it into an AC current. So those would be like our TENS units or our iontophoreser, okay, that does iontophoresis, the delivery of the medications. That takes a battery, a DC current, and keeps it a DC current. And then we can modify that wave based on the parameters we set. So the generator forms the wave and then we get to alter it with our parameters. So what happens when we put electricity into the body? Okay, when we put electricity in the body, this should be a review of kind of the nerve idea, but we get stimulation of a neuron. Okay, so membranes tend to be that they have more of a positive charge on the outside that's greater than on the inside. Okay, so the positive charges are greater than the negative charges outside, and then on the inside, the positive charges are less than the negative charges. And so usually that's maintained through the sodium-potassium pump. So an active transport of sodium ions go outside to keep that positive positive level, positive charge outside of the cell membrane. And that electrical potential is usually somewhere between minus 70 to minus 90 millivolts. So when depolarization happens, we get stimulation, and a rush of positive ions rush into the nerve, and negative ions rush out. And this causes a chain reaction, and that's what we call the action potential. As we change the intensity or the duration of the stimulus, so again, either the height of the wave or kind of the length of the wave, we can potentially end up changing the threshold. Okay, so changing intensity or duration does not necessarily change the threshold on one fiber, but it changes potentially which fibers we target. Okay, so then the action potential gets reached, right? So when we talked about depolarization, that all or nothing idea, when it reaches the axon terminal, then it has to cross the synapses, and that happens through the release of the neurotransmitters in order to stimulate the next nerve. A single motor neuron could synapse with many other fibers, okay, many muscle fibers, and that's what we call a motor unit. So by sending the signal down that one motor nerve, we can target many different muscle fibers and get contraction or relaxation. So like I said, all the fibers contract on that single action potential, and it's an all or nothing situation. So as long as all of the receptors are full for the neurotransmitter, the signal will pass. And once those start to retreat, the signal will stop. The level of the muscular contraction has to do with the number of motor units stimulated, not necessarily the activity level on the nerve itself. And then once that action potential happens, until the nerve is repolarized, no new stimulation can happen, and it's what we call a refractory period. So there's no action potential possible, and there's usually an absolute refractory period where there's absolutely no action potential possible, or a relative one where we can still potentially get an action potential if the stimulus is high enough. But usually that window is somewhere between 0.4 to 2 milliseconds. So we're talking very small times here. When stimulation occurs in our body, okay, we have the fact that stimulation occurs on mixed nerves, or our periphery nerves, right? They have sensory and motor nerves following on the same highway. And within there, we have, even within the sensory nerves themselves, we have different sizes and types of nerves. So thinking back to our nerve types, right? We have our A betas, which are going to be kind of medium in size, okay, the sensory. And then we had our C's, okay, we're going to be the smallest and the slowest of our pains. We had A deltas. So the different sizes are going to end up being how quickly the electricity can affect. Okay. So large fibers are more rapid in conducting, and so we get a greater response. They also usually have less of a threshold for excitability, but they're also usually a shorter duration. They kind of burn out. So they burn hard and fast, and then they burn out. But they also have usually a really shorter refractory period. The more superficial a nerve, the greater excitability. So our motor nerves tend to be closer to the skin, and so they're more excitable than some of our deeper pain, noxious stimuli ones. If a nerve has more resistance, it's going to have less excitability. So again, our skin serves as an insulator. The gel we put on a pad serves as a transmitter. So again, things that will affect the impulse and the sense that we get. The size of the nerve that we can target, the depth of the nerve, because it's going to take longer to reach those deeper tissues. There's more resistance to those nerves. And then the amount of resistance within the impulse. So another law for you, the law of Du Bois-Reymond. This talks about the fact that an intensity of the current must be intense enough to depolarize the cell membrane. So we have to be high enough to at least get through the cell membrane and to change that action potential, right? So that we end up with that rush of positive in and the negative out. The rate of rise of the leading edge of the pulse must be rapid enough to prevent the accommodation. That dealt with our rise time. We have to go fast enough that the body can't diffuse all those ions. The current must flow long enough in one direction to cause the nerve to depolarize. Okay, so the phase duration or potentially the pulse duration. So smaller diameter nerves require a longer phase duration or pulse duration to depolarize than the larger ones because of the resistance. And there has to be sufficient time allotted to allow the membrane to repolarize. So all that has to do with how the body responds to these electrical stimulations. So within the central nervous system and the peripheral nervous system, we have some interference that can happen. And so these three terms are really important. Accommodation, we've talked about it a little bit already. This is the rate of depolarization, the fact that that decreases while the stimulus remains unchanged. So your body gets, those cells and the nerve fibers get used to the level of stimulation. It comes on slow enough that the ions can diffuse, so we don't get the action potential. So when that is happening, we have to increase the intensity in order to reach the depolarization. So a slow rise time is more likely to allow accommodation to happen. And nerves are more likely to accommodate than muscle. Habitation is within the central nervous system. So the central nervous system tends to filter out continuous, meaningless stimuli. And so as we do treatments over a long period of time, so as we do this treatment over the week or a couple weeks, the body can tolerate more because of habitation. If within a single treatment, if we have to turn up the intensity, which we almost always have to do, that's because of accommodation. And then modulation is meant to help with both of these things. So randomly altering the pulse intensity, the frequency, or the duration kind of keeps the body guessing and keeps the flow of electrons and the membrane from being able to adapt. And so it reduces accommodation and habitation. So again, here's a point about those stimulation points in the body. So the motor points, the trigger points, and the acupuncture points, and why those points are potentially more apt to allow the electricity to flow. And so if we can use those points to our advantage, we can get a treatment with less intensity needed. So that's important to know. So I suggest you review that part as well. Final part in this section is what are those things that actually happen? So now that we know what physiologically occurs with the electrical current and how it flows in the body, what happens when we have these ions? So our goals of eStim are directly related to what can happen in the body when we apply the electricity. And so our typical ones are we can create muscle contractions through either nerve or muscle stimulus, almost always nerve. Muscle's pretty hard to target and it hurts and it fatigues. So that's usually only done when the person can't feel. So denervated nerve muscle tissue, but that's muscle re-education. We can stimulate sensory nerves to treat pain. Most of our TENS is going to be based on it, and it's going to be based on our 3 levels of pain control. We can create an electrical field on the skin that helps drive ions through. That's what we call iontophoresis. So we drive medication through the skin based on like charges repelling like. And we can create an electrical or chemical field in the biological tissue that can alter the healing process. It's what we call medical galvanism. And it's basically saying that if I drive ions or negatively charged electrons and then the negative ions through the body, one certain reactions will occur. And if I do positive ones, a different type of reaction will occur. So basically, if I switch the poles over the tissue I want to target, I can create different environments. It's kind of mixed results. Over here is a table from your book of basically summarizing these things. We can control acute and chronic pain. That was what we see over here. We can reduce edema. That has to do with some of the muscle contractions we can create. We can reduce muscle spasm either by treating the pain or by potentially overriding that likelihood to spasm with some of the muscle contractions. We can inhibit muscle spasms, same as reducing joint contractures, again through that muscle re-ed. If we can contract those muscles around it, even when the person can't actively do it, we can hopefully reduce some of those joint contractures. Minimize atrophy, same thing. If we can't use the tissue, we can potentially use electrical stim to target that. Facilitating tissue healing, some of the medical galvanism, as well as if we treat the pain, right, the body is more likely to not be in spasm, which can allow tissue healing to occur. We can facilitate the muscle re-education. There's even fracture healing. That usually requires a separate generator, so we're not really going to focus on fracture healing in our class. You can read up more about it in the book. But basically you would need a special device to be able to target the bone, and usually those either have implanted electrodes or different types of electrodes that we would use. Strengthening muscle kind of goes with the muscle re-ed. There's debate on that, and you really only strengthen isometrically because you're only getting a contraction, not movement with it. So it's not usually helpful in the long run, but it can be if you have some of these other conditions. And then affecting orthostatic substimulation. So the fact that we can get some of those forced contractions and potentially help during gait. That's usually more so during stroke rehab and paralysis rehab.